Welcome back. Your host, Dr. Kishore Ratkalkar, here with Dr. Christine Greiss, discussing concussion, brain injuries, and in the last segment we just discussed concussion, and now we'll move on to a much serious problem, which is traumatic brain injuries. And traumatic brain injuries again are moderate and severe, but I'll let our expert here, Dr. Greiss, explain to us what happens in traumatic brain injuries and what we can do to help ourselves through this process. Thank you, Dr. Greiss.
Thank you, Dr. Ratkalkar. And so in discussing traumatic brain injury, we always look at the mechanism first. Generally with traumatic brain injury, the sense of the definition is that there was something present on imaging. There was some structural deficit in the brain itself.
Unlike concussion.
Unlike concussion,
Yeah.
which it won't appear on a
Sure.
typical conventional MRI report of the brain.
Sure.
When it comes to moderate or severe brain injuries, as being a structural problem that we could see on the image, we tend to see natural bleeds of the brain in different aspects of the brain, different layers, because the brain has many layers. And based on where the bleeding happened, can really affect prognosis.
Okay.
So for instance, if a person falls on the side of their head, we can have somebody standing and having fun on a table and then they lose their balance, they fall to the side, they may sustain an epidural hematoma.
Okay.
That's different because if they survive it and it's outside the brain tissue and they survive the first 24, 48 hours, their prognosis is excellent.
Okay.
They do pretty well. We see them in the clinic. Sometimes the trainees are surprised that they're able to go back to driving and working within a matter of a month and a half.
That's wonderful.
Which is amazing. But then we see some of the bleeds that are actually embedded under that inner wall of the skull and under the dura. And so we see sometimes the subdural, what we call them subdural hemorrhages. They don't tend to resolve as well. They take longer because the brain has to put in more work to absorb all of that blood
the fluid.
and all the flood and fluid, and then normalize the pressures.
True.
So that takes a little bit longer time. We also see the bleeds that are subarachnoid hemorrhages. They tend to come with their own basket of problems. So if you think about, for instance, dropping your phone in the water, the whole electrical system won't work very well. And so you always think about these subarachnoid hemorrhages because the arachnoid villi actually transmit CSF into the brain.
Right.
And when it happens, they're prone to seizures after the injury. They're the ones that are prone to hydrocephalus, other complications.
The swelling of the brain.
And the swelling itself.
Right.
So there's a lot of issues with the brain itself in terms of manifesting, and dealing with all of that edema or swelling. When it comes to the severe brain injuries, there may be nothing on MRI except the speckled snowstorm, what we call appearance on the image. It's called diffuse axonal injury. That's in high-speed motor vehicle and motorcycle crashes. We see those are the patients that we call in a coma.
Mm-hmm.
Some are in a vegetative state, which is different from a coma because that's a presence or absence of them sleeping and waking up.
Right.
And then there's the minimally conscious. Those are very different because all the wire is doing is it was stretched. So think about, for instance, a phone charger. We all have those chargers that if we tug at them long enough, then we plug in our phone, it won't work.
Correct.
Because the outer lining, which is the nerve has a nice coating around it, that outer coating is stretched, it's pulled, and that membrane is damaged. And that happens across the entire system, the central operating system, the brain, and therefore the patient is not conscious. They're not awake. We also manage those patients.
That's what you call vegetative state.
Yes. I also am proud to be working at JFK where we developed early in the 2000s the JFK coma recovery scale.
Okay.
Until this day, we are implementing it after their work, and it's known nationally as the ability to track a patient as they're emerging from a coma.
That's
and they're
wonderful.
regaining their consciousness.
That's wonderful.
So sometimes we try to get the patients to give them stimulants, sleep medications, to kind of help them regain awareness of their surroundings and memory of everything that happened.
Okay, great. You have a very good brain injury trauma unit. Can you share with our viewers the unit that we have at JRI, at JFK University Medical Center?
It's my pleasure. I work with a wonderful team. It's really the team approach. We have, besides the physicians, we have the brain injury fellow, we have resident physicians, but then all of our staffings, we have brain injury certified nurses, and they are very familiar with what brain injury complications look like. Okay. They manage complex patients. And when it comes to also neuropsychologists, we have a neuropsychologist every day doing this coma recovery scale with our patients, which is wonderful.
And then the families are involved in that.
The families have to be involved. We call them care companions. Right. Because sometimes it's great to see or hear, as a person is under this vegetative state, to hear a loved one, a familiar sound.
That is awesome.
So that is wonderful. We have a team of physical, occupational, speech therapists, and recreational therapists. So they're getting 3 + 4 hours of therapy a day, 5 to 6 days a week, just working on emerging and recovering from, this trauma. So besides that, we also have a great team of all of the aides, and we have a great team of social workers, because they are equipped in all the resources available to help their patients and their families regain the ability to care for their loved one. This is the most life-changing event for families.
Absolutely.
So we always try to see all the resources possible in the community to help these patients return home. And the nice thing is we also have them follow up with the physicians in the outpatient basis until, they're stable.
So usually, you have intensive care unit, and then you have the brain trauma unit. So patients who are moderate or severe traumatic brain injuries, first when they are stabilized in intensive care, you bring them over to your unit.
Yes, correct.
And because of what you have there, the outcomes are much better for patients with brain trauma injury. And that's why JRI is one of the nationally recognized centers for excellence, not only in New Jersey, but only nationally, as I said. It's one of the top programs. And because of clinicians like you make a difference in patients who have traumatic brain injuries. And we thank you for that. We're going to take a short break, and we'll return after this break. Thank you so much.